Hello and welcome to OffBlueMedical. Today we will be taking 10 quick notes for the USMLE. This benefits step 2 and step 3 more than step 1. So the first note, and all of these are high yield notes. The first note says, if a question says fixed retroverted uterus, it strongly hints towards the diagnosis of endometriosis. So on a question, if you see it says retroverted uterus and it's fixed, then that means basically it's endometriosis. But sometimes the question might just say retroverted without saying fixed, and it would also mean endometriosis. But this is not always the case. It might say a retroverted uterus and it's not going to be endometriosis because it could be normal. So you might say, what does retroverted mean? Well, basically, version is the relationship of the uterus or cervix to the vagina. So that means it's going to be posterior. So if I draw the vagina, this is going to be the vagina and this is going to be the uterus. So as you can see, the uterus right here is going to be posterior to the vagina, which is going to be more anterior to the uterus. The second note says, if a question mentions a mass that doesn't cross the midline of the abdomen and doesn't change with movement of the lower extremities, the diagnosis is going to be rectus sheath hematoma. So this is also called the Fothergill sign. The third note, when you see a young woman with no risk factors for myocardial infarction and coronary artery disease that presents with chest pain similar to a STEMI, with the D dimer going to be increased, and she also has increased troponin T levels. They are extremely high, they may be 100 or more. The diagnosis is going to be spontaneous coronary artery dissection. And you may have never heard of this diagnosis because this is a low yield, often ignored condition. But when you take the step 2, you want the maximum grade possible, you want the maximum score possible for step 2 and step 3. So this is a low yield condition, but it may come up. So this is basically an intimal layer tear of the coronary vessel leading to a hematoma formation in that vessel, and then you get coronary artery dissection. This is seen in middle-aged and young females. They are often younger than 50, and the risk factors are connective tissue diseases and fibromuscular dysplasia and intense stress. The ECG could be abnormal, it could also be normal. So you shouldn't rule out this condition with the ECG being normal. And the treatment, shockingly, is conservative. You don't do anything. You just treat it, give it maybe aspirin, beta blockers, ACE inhibitors. It will go away on its own. You don't need to do anything. Patients with Down syndrome have a significantly higher risk for obstructive sleep apnea, largely due to a unique physiological factors like structural airway differences and hypotonia. So what am I trying to get at? I'm trying to say that every child with Down syndrome should undergo polysomnography, which is a sleep study, as a standard screening measure. You can include this in the screening measures. Every child with Down syndrome, they should undergo serial sleep studies, regardless of whether they show obvious symptoms or not. In older patients or those previously cleared, a sleep study is necessary if there are sudden unexplained changes in behavior or mood, as poor sleep quality is often the underlying culprit. So basically, if you see a Down syndrome patient getting agitated, what are you going to do? You're going to do a polysomnography. Why? Because they may have obstructive sleep apnea. When they have obstructive sleep apnea, they have less sleep. They have less sleep in obstructive sleep apnea, and their quality of sleep is going to be decreased. So they become agitated during the daytime. So you do a polysomnography, which is a sleep study. The fifth note is regarding proximal femur fractures. So if you see a femoral head fracture, that means there is a hip dislocation due to a high energy trauma. If you see femoral neck or intertrochanteric fractures, that means this is probably due to osteoporosis. And subtrochanteric fractures, are commonly due to bisphosphonate use. Avulsion fractures of the lateral tibial plateau are associated with anterior cruciate ligament injuries. So sometimes a question might not bring up the standard MRI image showing you an ACL injury, an ACL tear, an anterior cruciate ligament tear. They might just say there was an avulsion fracture of the lateral tibial plateau. What could be associated with this injury? You're going to answer anterior cruciate ligament. If they say lateral tibial plateau injury or fracture, avulsion fracture of the lateral tibial plateau, what are you going to answer? You're going to say anterior cruciate ligament tear or injury. The other note is regarding alopecia areata, seen as in this image, as you can see right here. So the diagnosis of alopecia areata is clinical. There's no need for biopsy, even though it's an autoimmune disease. You don't do biopsy. It's clinical. It presents as painless, patchy hair loss that's non-scarring. So it's not going to be causing scars. Sometimes, if we zoom in on this, you might see exclamation point hairs like this. You should, however, since it's an autoimmune disease, then that means it's going to be associated with other autoimmune diseases, and you should screen for other autoimmune diseases such as thyroid disease. Maybe you'll order a serum, TSH, to screen for that. Note 8 says, bacterial aspiration pneumonia is dangerous in advanced Parkinson disease. So if there's a patient with advanced Parkinson, they might aspirate food, they might aspirate fluids, and they might contract pneumonia. So you should do serial swallow evaluations as the disease stages advance, and you should also modify consistency, such as thickened liquids, and also adjust eating positions. The other note, which is a classical note, if you see an altered mental status in a patient with an acute exacerbation of COPD, which is chronic obstructive pulmonary disease, you should think of hypercapnic encephalopathy. So CO2 levels are going to go up, and this is going to be causing a hypercapnic, meaning an increased level of CO2, encephalopathy. The last note is regarding digoxin toxicity. So there's a difference between the acute and chronic digoxin toxicity. The acute digoxin toxicity presents with gastrointestinal symptoms such as anorexia, nausea, vomiting, abdominal pain, while as chronic toxicity of this drug presents with less pronounced GIT symptoms but more neurological symptoms and visual symptoms such as changes in color vision, scotomas, and blindness. And these are the 10 notes that are helpful for the USMLE.